the next star speaker. It's my pleasure and a great honor to introduce the next speaker. It's Prof. Adel Hussein. It's my Prof. Dr. Adel Hussein is Assistant Professor Critical Care Medicine, Cairo University, consultant, big consultant in King Abdullah Medical City. Dr. Adel, he was the head of Department of ICU in King Abdullah Medical City, and really I enjoy to work with him every day. Dr. Adel will introduce today the myorelaxant in ARDS patients, or the role of muscle relaxant in ARDS patients. So Dr. Adel, please, all of you waiting you, please go on.
Thanks, Dr. Mohammed. بسم الله الرحمن الرحيم. بداية الحمد لله رب العالمين والصلاة والسلام على أشرف خلق الله والمرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. نسأل الله تبارك وتعالى أن يجعل ما نقدمه الليلة خالصا لوجهه الكريم وأن ينفع به يا ربي دائما مرضانا والبلاد والعباد. First of all, I have to thank Dr. Mohammed for his very nice introduction to me. I'm actually enjoying being tonight. He's my moderator. Really, I'm really delighted and enjoyed. Also, I have to thank on behalf of the ICU department of King Abdullah Medical City in Makkah al-Mukarramah. We have to thank Dr. Saad to give us this opportunity tonight for me and my colleagues, Dr. Faisal. And Dr. Sarwat was one of our eminent colleagues, intensivist, joined us for almost 4 years. Then now he is in Ireland. We are really glad and delighted to invite us, Dr. Saad. Jazakallah khair. Thanks a lot. And also, it's difficult tonight because my title, difficult to me because my title is about muscle relaxant or myorelaxant, and myorelaxant in the ARDS patient. Difficult to me, why? Because I'm talking about the myorelaxant among stars of anesthesia, anesthesiologist consultants. So for you, it's a piece of cake. But for intensivists, including myself, it's a hard topic. And it's really something all the intensivists from residents to fellows up to consultant, we have to be aware about it because it's one of core management, or we call it frontline adjunctive therapy in in ARDS patient. So for anesthesia, I think my presentation today, it's something easy. I will not add a lot for you, I'm sure, because it's your daily practice. But I hope, inshallah ta'ala, I may add something for my colleagues in the critical care career that inshallah ta'ala may improve their practice and of course the knowledge to manage the ARDS patient. So before to go on my presentation, my screen is clear and my voice is clear, Dr. Mohammed?
Yes, it's clear. Go on, please.
Okay. طيب. على بركة الله. So for tonight, I have nothing to disclose with my presentation. Why I'm here tonight among you guys, because I want to update us on the role of neuromuscular blockade agents during mechanical ventilation, especially in ARDS patients. Why from what point of view? This will be based on a pathophysiological concepts and data obtained from randomized controlled trials and evidence-based. And of course, those ARDS patients, they are our daily challenge in the ICU management, especially after the COVID era. And in the next few minutes that I can cover the role of myorelaxant and its role in the management of ARDS, and does it have a role in survival or no role at all, or it has some role to add as a frontline adjunctive therapy and the ARDS management. So the objectives of my presentation tonight, I will highlight some pharmacology about the neuromuscular blockade. Second, about the plausible beneficial effect of neuromuscular blockade in ARDS patients, the so-called plausible or beneficial effects. Third will be about the biological effects of the neuromuscular blockade. Fourth, about the risks of the spontaneous breathing in ARDS. Fifth will be about the safety concerns about the neuromuscular blockades. Six, a few slides will be highlighting the monitoring tools for the neuromuscular blockade used in ARDS patients and ICU in general. Number 7, I will highlight the sedation monitoring also while a patient is receiving neuromuscular blockade. Number 8, something should be mentioned about the outcome of ARDS patient receiving those myorelaxants. And I will sum up with summary of the main clinical recommendation for the neuromuscular blockade use in clinical practice اللي احنا هنسميها بالعربي يعني الزبدة خلاصة البرزنتيشن tonight. This is a very nice algorithm for managing ARDS patient. I'm encouraging everyone working as a frontliner to manage the ICU patient to have this algorithm with him. It's a very updated, it's dated 2019, so just like 1 year ago. It's highlighting the role of interventions that evidence-based now for managing the ARDS, including ventilatory and non-ventilatory, in terms of cascading and grading based on the definition, as Dr. Sarwat mentioned earlier, based on the BF ratio. So my rule here is for my relaxant is with the BF ratio of less than 150. Less than 150. This is the rule of neuromuscular blockade. As well as طبعا prone positioning, and I think this will be the title for my the next colleague and star also with us, Dr. Faisal Tatar. So for me, my rule is here as a neuromuscular blockade is at the definition of moderate to severe ARDS, starting with BF ratio less than 150, and the conclusion when to use it, we will go through when to use, the timing, how to use, which monitoring tool. So this is the aim of my presentation tonight, inshallah ta'ala. And also another algorithm which also depicting the role of different interventions based on BF ratio as well. So again, I'm just repeating this for the role of BF ratio or the role of intervention based on the BF ratio. After you adjust your ventilatory settings, you titrate your sedation, and still the patient is not improving, then you are looking here for the BF ratio and to start to use the protective lung strategies. And here, if the patient already is not improving after you exhaust your ventilatory tools or conventional ventilatory tools, you use the protective ventilatory settings. As Dr. Sarwat mentioned, with different modalities, but still your patient is not improving, and you cannot achieve the protective lung strategy, and the PF ratio still is less than 150. So here is the role of neuromuscular blockade. So mortality in patients with ARDS, as all we know, remains despite significant advances till 2020. It's particularly still high, especially in the management of patients on mechanical ventilation. One of the common non-ventilatory strategies used in the treatment of ARDS, and we consider it as a frontline adjunctive management, is the early administration of neuromuscular blocking agents. As all we know also, COVID-19 pandemic is associated with ARDS, prevalence of ARDS. So one of the core management used was the neuromuscular blockade as non-ventilatory strategies. And because of the excessive use of the neuromuscular blockade, there was a significant shortage, like other interventions, like other equipments in the COVID pandemic. It's worldwide. And this shortage expressed in different countries, suggesting that there is a widespread use of neuromuscular blockade in the management of ARDS. The respective roles of mechanical ventilation with preserved spontaneous breathing and completely controlled mechanical ventilation using the neuromuscular blockade, it's need to be clarified, both to be clarified and addressed when early in the phase of ARDS. So once you define the ARDS, by definition, so early in the phase, you have to balance the there is an injurious role for keeping the patient has spontaneous breathing, or the patient should be completely controlled, knocked down using the neuromuscular blockade. So those two strategies should be complementary and defining the appropriate timing. Appropriate timing for Browning, appropriate timing for neuromuscular blockade, an appropriate timing for protective lung strategy, and also what we call protective diaphragmatic strategy. Of various pharmacological measured study among the pharmaceutical interventions in the ARDS management, only the neuromuscular blockade have been shown to decrease the 90-day adjusted mortality. So only proved till now, till 2020, that the neuromuscular blockade have a strong role in managing of patients with ARDS. And I will tell you why in the next few minutes. For the use of sedatives, opiates, and neuromuscular blockade, since 2008, it was addressed the role of, and even before, for this publication in the Critical Care Medicine Journal. So before the publication of the studies regarding the use of neuromuscular blockade that I will show you later on, their use was not trivial. They are using since even 2000, 2002, 2004, but they were not addressing that in a randomized controlled trial or in a guidelines. The alveoli trial in 2008, they addressed the continuous use of neuromuscular blockade with using lower and higher PEEP, and other factors also they were found were associated with the neuromuscular blockade in the alveoli trial, that the high Apache score, the wide A gradient, and the high plateau pressure. Also, or moreover, the prone positioning, the so-called permissive hypercapnia to ensure protective ventilation, ECMO, and high-frequency rate ventilation may require the use of neuromuscular blockade. So not only the conventional ventilation is an indication to use the neuromuscular blockade in ARDS, but as I mentioned here, is for the permissive hypercapnia, you may need to knock the patient down, prone positioning. Though some centers, they may advocate or use the proning positioning without muscle paralysis still. ECMO, high frequency, of course. There is other indications for use of neuromuscular blockade in the ICU, but is not within the scope of my presentation tonight. Moving to the pharmacology of neuromuscular blockade, just to remind our ICU, I think the coming slide is not so important to our colleagues in the anesthesia colleagues, but it's mainly for ICU because they are very familiar, our colleagues in the anesthesia, they are very familiar with what I'm talking now. But for the intensivists, sometimes we miss some basics. So all we know that the neuromuscular blockade, they cause muscle skeletal relaxation. How? By blocking the acetylcholine receptor at the neuromuscular junction. They are classified based on the mechanism of action and the chemical structure, and this is very important, into two main categories, either depolarizing or non-depolarizing neuromuscular blockade. The depolarizing, it bind and activate acetylcholine receptors, while the non-depolarizing from its nomenclature, it bind and competitively antagonize the acetylcholine receptors. So this is based on the time of action, either short acting or short, intermediate, long acting. For the depolarizing, Myorelaxants. So we have the short acting is the only one we have it is the succinylcholine, of course. For the non-depolarizing, we have short acting, we have intermediate acting, and we have long acting. This is usually is important for us in the ICU. I know most of us in the ICU, we are rounding with a critical care clinical pharmacist. He adjusts with us the medications. He highlight with us the drug-drug interaction. But for intensivists, because they are the one who is prescribing those important high alert medication, you should know about who is short acting, who is intermediate acting, who is long acting, who is depolarizing, who is non-depolarizing, who can use as continuous infusion, who cannot use as a continuous infusion, who can use with patient with liver impairment, who can use with patient with acute kidney injury. And of course, our patients in the ICU, they are not only single organ as ARDS, they have liver failure, they have acute kidney injury, they are in dialysis, they are in ECMO. So of course, it's one of our job here is to know about those medications. First, because we are the prescribers. Second, because it's high alert medication, so I should be aware about it. Why I'm prescribing, how to prescribe those important medications. Sux is the only depolarizing agent, but is not used as a continuous infusion, as only we know. It's for intubation purposes, but not for continuous infusion in critical care settings. While the non-depolarizing neuromuscular blockade, it's subdivided into two categories. One category is called benzyl isoquinoline, which is, for example, and this category is the atracorium. Cisatracorium is two famous neuromuscular blockade, while the other category under the non-depolarizing myorelaxant is the amine steroidal compound. And the example for this is the rocronium, bancronium, and vicronium. The steroid compounds or components appear to be further favor the occurrence of myopathies because of steroid content, or the aminosteroidal content or compound within its structure. It's favoring the occurrence of myopathies because of this structural analogy. Just some important points about the aminosteroidal compounds and the other class, which is the benzyl isoquinoline. The aminosteroidal compounds is metabolized into active metabolite, which is very important. Their elimination of these metabolites can be disturbed by renal and liver failure, another important statement. And still they have a risk of accumulation. So if you are talking about vicronium or bancronium, so it's those aminosteroidal, it fit here. While for cisatracorium and atracorium, they fit under this group, which is the benzyl isoquinoline. It mobilizes into inactive compounds by the plasma esterases. There is no risk of prolonged neuromuscular blockade blockage after discontinuation of the infusion in ICU patients with renal and liver failure. And those are two unique and important features for this class. Just to, when you read or you hear about what's the Hoffman elimination, I know this is something for pharmacology, this is something for clinical pharmacists, but for you as intensivists, you have to be aware about it. So what's Hoffman elimination? It's a spontaneous, based, catalyzed, non-enzymatic chemical reaction. By the Hoffman elimination, the atracorium is cleaved into two molecules. The alkalosis increase the resistance to atracorium-induced neuromuscular blockade. So you have to be aware about if your patient have alkalotic pH and you are using atracorium. So be aware about that. There is some resistance can be developed for the atracorium that it may lead to increasing the dose of atracorium. Hypothermia also, it slows the temperature, so it slows the breakdown. So less atracorium is required to maintain the neuromuscular blockade depth. So be aware about the alkalosis, be aware about the hypothermia. Atracorium and cisatracorium are the preferred agents of continuous infusion in critical care settings. Why? Simply because their metabolism is unrelated or non-related to renal or hepatic function. They have inactive metabolites, and both are intermediate acting. They are not long acting. For the atracorium, if you just you want to have something from base or core of pharmacology, the atracorium is a racemic. It's a mixture of 10 isomers. So the activity of different isomers can vary among those 10 isomers. It is metabolized through non-specific plasma esterase-mediated hydrolysis plus the Hoffman elimination that we talk about. So it's independent of hepatic and renal function, but it has a histamine release. So those patients, when you use atracorium, be aware about that they may have some anaphylaxis, some hypotension, some flushing because of the histamine release. It's an attractive option in critical ill patients with renal and hepatic dysfunction, of course. Moving to cisatracorium in comparison, it's one of the isomers. احنا قلنا انه atracorium is 10 isomers. The cisatracorium is one of those 10 isomers, but it's unique in its function and potency. It has fourfold potency in, more than the atracorium without associated the histamine release. When you compare the atracorium to cisatracorium is fourfold potent, and it does not have a histamine release adverse effect. It is metabolized through organ-independent mechanisms through the so-called Hoffman elimination. It's one of the most commonly utilized neuromuscular blockade in critical ill patients when you decide to use a neuromuscular blockade in them. Just I will show you just very quickly, because this is something very basic and all of us, we should know about the neuromuscular blockade or the myorelaxant in terms of their intubating dose, the onset, the infusion dose, the duration of action, and the route of elimination. Especially, we are commonly using the SACs. Some centers, they are using the recronium. In the shortage, you may use pancronium. Ideally, we should have the cisatracorium and the atracorium. So, interestingly, if you compare, as I mentioned, the cisatracorium and the atracorium, they are using what they call it ED95, which is the effective dose of 95%. As a definition. This is very a famous term among the clinical pharmacists, and the definition of this ED95, when they talk about one of neuromuscular blockade in comparison to the others, they are mentioning what's its ED95. It's the amount of the neuromuscular blockade required to reduce the twitch of the muscle, as we will highlight it later on during the monitoring with TOF, by 95%. So this is the dose required to reduce the muscle twitch or the amplitude or the height of the muscle twitch while you are monitoring with the train of 4 or with the TOF ratio. So atracorium has a shorter time of onset when compared to cisatracorium in equipotent dose, almost, so double the ED95. Duration of neuromuscular blockade and the recovery profile of both drugs are almost comparable. Okay, for critically ill patients, to use cisatracorium or to use atracorium, which to use? What's the evidence behind both? Any trial favoring cisatracorium over atracorium, or the reverse, any randomized control trials available favoring the use of atracorium over cisatracorium? We will see. So this was a trial published in the Respiratory Care in journal in 2017. They compared the cisatracorium head-to-head versus the atracorium early in ARDS. It was a retrospective evaluation, but single center study. It was conducted from 2012, or they collected the data from 2012 to 2015 over 3 years. They included very small number or small size, about 76 patients in total. 18 they received atracorium, 58 they received the cisatracorium. The neuromuscular blockade were used within 72 hours post ARDS presentation. Only those with BF ratio less than 150, they use it as one of the inclusion criteria for starting the neuromuscular blockade, either head-to-head. So this is one of the few studies that they compare cisatracorium head-to-head versus atracorium. Though it was a small sample size, it was a retrospective, it was a single center study, but these are the comparison data regarding the mechanical ventilatory strategies, regarding the ventilatory modes, regarding if they are using non-ventilatory modes like proning position, and they address also the here the plateau pressure, the APRV, and if we can look here, there was no significant difference regarding the p-value. Again, for comparing atracorium versus cisatracorium for ICU length of stay, for hospital length of stay, also for hospital mortality, BF ratio before and after the intervention, BF ratio improvement, and also ventilator-free days at 28 days, there was no significant difference. So among the subjects with early severe ARDS, they concluded that utilization of atracorium versus cisatracorium within 72 hours was not associated with significant difference in the outcome or in the clinical outcome, as I showed you. What about the cost analysis? This was a study published in 2013 regarding the cost analysis and the safety regarding the cisatracorium and atracorium. The previous study was the clinical outcome. Here is the cost analysis and safety. And they concluded that atracorium and cisatracorium had similar safety profile, both. Atracorium had a cost benefit relative to cisatracorium because the cisatracorium is costly, more expensive than atracorium. And patient with instability in their hemodynamic parameters, cisatracorium was the appropriate choice. So this was very important conclusion and statement. If your patient is hemodynamically stable, like our patients, we have it in the ICU because of the heavy sedation, because of their sepsis, because of their other contributing factors, they are hemodynamically unstable. So cisatracorium, if it is available, so it's better to use. طبعا we mentioned earlier that the atracorium has the adverse effect of being a histamine releaser. So yeah, if your patient is hemodynamically stable, use and they have the luxury to use cisatracorium versus atracorium, please use the cisatracorium. And also this is a prospective randomized comparative study comparing the efficacy of the atracorium and cisatracorium during general anesthesia. This was not in the ICU patient. This was during the general anesthesia. It was a prospective randomized controlled trial. It was published in 2019, last year. It was a prospective randomized comparative study. They included 156 patients, de-randomized into two groups. One arm is for cis and the other arm is for atracorium. Patient duration of surgery, vital parameters, intubation score, all were recorded, and they concluded that the cisatracorium with lesser side effects and a better hemodynamic tolerability and more efficacious or more effective when it's compared to cisatracorium. So now we have one trial now in general anesthesia or in the OR. We have two trials in the ICU comparing the clinical outcome, the safety profile, and the cost of cisatracorium head-to-head with the atracorium. Moving to the plausible effect or beneficial effect, this is the next topic in my presentation. So they found that there is plausible beneficial effect of neuromuscular blockade, especially in ARDS patients. So favoring the use of neuromuscular blockade, what are the beneficial effects that were reported? It favored the thoracopulmonary compliance, the functional residual capacity, the VAQ ratio, and the its mismatch, the redistribution of the blood flow to the splanchnic vascular beds, recruitment of low compliance area and PEEP maintenance, adaptation and compliance to the protective ventilatory strategy, plus they found that they have an, interestingly, an anti-inflammatory effect. Moreover, it prevents the patient ventilator asynchrony. It prevents the overdistension with high compliance lung zones. It prevents the de-recruitment and the atelectasis trauma. It prevents the biotrauma, which is related to the inflammation. So we call it biotrauma, not barotrauma. It's a biotrauma. It prevents or decreases the oxygen consumption, and of course, it prevents the high respiratory efforts if you knock patient down. So those favoring and preventing plausible effect are in favor or encouraging the plausible effect or beneficial effect. What about the harm from using neuromuscular blockade? It may increase the ICU acquired weakness, the need for heavily sedating this patient before starting the neuromuscular blockade. And all of us, we know about the consequences of both deep sedation and heavy paralysis. And also the duration of sedation during the neuromuscular blockade use. So those, they were found from their literature, and I will highlight more details about the ICU acquired weakness. So as we mentioned, for those harmful effects, it's very important to be on your mind regarding the ICU acquired weakness, the need for heavy sedation, and they may increase the duration of sedation. So in your mind, when you have to use the neuromuscular blockade in ARDS patients, so you have some pros and some cons. So as we mentioned earlier, there is some data supporting the data, so supporting the use of neuromuscular blockade, and there is a positive outcome about the ICU-free days, the improving the oxygenation, decrease in the barotrauma, decrease the ARDS mortality, and decrease the ventilator-free days. On the other hand, for the cons or drawbacks with using the neuromuscular blockade in an ARDS patient, the risk of insufficient sedation or memorization after recovery from ARDS, the lung atelectasis, of course, the ICU acquired weakness, especially if you are combining those medications with corticosteroids, plus the risk of anaphylaxis. The neuromuscular blockade have multiple, as I mentioned, positive biological effects. In moderate to severe ARDS, they found that the neuromuscular blockade has been associated with lower local and systemic release of inflammation, so they considered as anti-inflammatory. Now I'm talking about biological effects. So systemic and local release of inflammation, so they are common with ARDS patients. So neuromuscular blockade has anti-inflammatory effect. They have effect on the epithelial dysfunction, so it lowers the epithelial dysfunction with its consequences, and the release of the biomarkers like interleukin-8 and surfactant protein D and von Willebrand factor. They have a direct anti-inflammatory effect as it's related to the cisatracorium, and this is based on its broad expression of its receptors, where in the epithelial cells, endothelial cells, leukocytes, and fibroblasts, and all of those cells are available in the lung tissue. So it has a direct inflammatory effect. This is how significant it's reported as a biological effect, but still it needs a further research and further proof that we have this translated into a clinical outcome. The cisatracorium, as I mentioned, it has an intrinsic anti-inflammatory properties, and its lung protection was primarily independent of its effect in the synchrony. So the intrinsic anti-inflammatory effect, it's one of its unique also properties. But the putative direct anti-inflammatory effect of cisatracorium needs to be counterbalanced by the muscle atrophy and the weakness associated with the prolonged use. So do not be happy with prolonged use of heavy sedation and muscle paralysis or cisatracorium, being that he has a direct anti-inflammatory, because on the other side, he has some harms. Most importantly is the muscular atrophy and the ICU-acquired weakness. Moving to the next about the risks of leaving patients with ARDS with the spontaneous breathing. And I think this was addressed starting from the COVID pandemic. And I think Dr. Sarwat was highlighting this in his presentation, and Professor Gattanoni, he addressed it a lot in many of his editorials and literatures, publications. And we heard about the patient self-inflicted acute lung injury, but just I will highlight it here how serious or how harmful will be the spontaneous breathing if the patient had moderate to severe ARDS. So if your patient has a vigorous spontaneous effort, this is really will lead to a global overdistension. It will lead to a maldistribution of the lung stresses and local overdistension. It will increase the lung perfusion and lung edema, of course. It will lead to patient ventilator asynchrony. It will lead to a de-recruitment. So those are common contributing factors when you have a spontaneous breathing. Your patient has spontaneous breathing while he has ARDS. At all, we know that patient respiratory drive and effort may be very high in the settings of ARDS. Why? because there is a big dead space, there is a metabolic acidosis, stimulation of the pulmonary parenchyma receptors, as well as the brainstem inflammation and the cortical stimuli. And we found this elaborated clearly in COVID-related ARDS or COVID pneumonia ARDS. The spontaneous breathing efforts, as we mentioned, it may worsen the lung injury by different mechanisms we mentioned early. When the spontaneous breathing effort is vigorous or high, we call this, as a consequence, patient self-inflicted lung injury or PSILI. Just I will move forward regarding the safety because of the time, regarding the neuromuscular blockade and its safety concern. So there are three major concerns about the use of neuromuscular blockade in ICU patients. Sorry. First is the ICU acquired weakness. Second is the ventilator-associated pneumonia, VAP. And third is the pressure and corneal ulcers. So if we want to talk about the ICU acquired weakness, it's a heterogeneous group of disorders, not only related to the use of neuromuscular blockade, but because of the disease itself, because of sepsis, because of the steroids, because of the heavy sedation, because of the organ failure. So we have different entities overlapping, and you may have a heterogeneous disease or overlapping disease. You may have critical illness myopathy, you may have critical illness polyneuromyopathy, you may have critical illness polyneuropathy, different entities. And also, you may have prolonged neuromuscular junction blockade. If I would like to ask you about the incidence of ICU acquired weakness. How much is the incidence of this? The muscle weakness being a long-term sequelae of critical illness, it affects roughly about 2/3 of ICU survivors. You can imagine up to 60 to 65% of critical ill patients, they may have ICU acquired weakness. And as I mentioned, there is many contributing factors for this high incidence of ICU acquired weakness. The sepsis, the immobility, the uncontrolled blood sugar, the drugs. Among the drugs, I have the neuromuscular blockade on top of the list, the aminoglycosides, corticosteroids, cholesterol on board. So we have to be aware about the wise use of neuromuscular blockade, especially with drugs, or especially with interaction to those medication. Your patient will use one of those or in combination. He, of course, if you are managing patient with ARDS early, so you may use, especially if he is a COVID ARDS, so you will use the steroids, of course, for the first 10 days. So neuromuscular blockade with steroids. For secondary bacterial infection, you may use antibiotics. If the patient develop MDRO, so you may use colistin. So it's very important to address this risk. Your patient is immobile. Your patient has uncontrolled blood sugar because of steroids, being diabetic, because of his sepsis. So those are common contributing factors should be addressed while you manage your patient, and you have to highlight all tools to prevent this ICU acquired weakness. What are the prognosis and the consequences of ICU acquired weakness? Per se, the ICU acquired weakness is an independent risk factor for increased duration of mechanical ventilation, of course, increased weaning duration, increased ICU, both ICU and hospital length of stay, and increase in the in-hospital mortality. If we are talking about mortality, about 45% within their hospital admission, they have a high rate of mortality because of almost 45 and close to 50%. 20% or more, they die within 1 year of discharge. So if patient develop ICU acquired weakness and discharged from ICU, 20% of them, they may die within 1 year as a consequences of this ICU acquired weaknesses. Regarding morbidity, higher, up to 68%, they have complete functional recovery. 28, close to 1/3 of them, 28%, they will develop a severe persistent disability, motor disability. Poor functional status is not a small number. It's up to 28 to 30%, 1/3 of their patients, they will develop persistent severe disability. So we consider it as a high morbidity and high mortality related to the ICU acquired weakness if you do not address and you develop either a protocol or a management plan, but it should be on your in your mind every day. You are managing your patient with ARDS, especially if it's a neuromuscular blockade. So the risk of persistent paralysis is higher in patients with hepatic or renal dysfunction. Duration of drug infusion and concomitant use of aminoglycosides and corticosteroids are risk factors. The use of special neuromuscular blockade that it has a chemical structure that incorporates a steroid moiety or analog, it will increase the risk of ICU acquired weakness. Namely, I'm talking about atracorium. Cisatracorium, as I mentioned, is unique and an exception. It has a different clearance and different structure. Moving to the evidence-based, currently we have two famous trials. One published in 2010, they call it a Curacious trial. And this trial was published in the New England Journal of Medicine. They addressed the neuromuscular blockade early in ARDS. And they concluded that in patients with severe ARDS, early administration of the neuromuscular blockade, it improved the adjusted 90-day survival and increased the time of ventilator. But it does not increase the muscle weakness. And this was very important. 2010, we have an evidence there is a decrease or no role for increasing muscle weakness while you use the neuromuscular blockade early with judges use or wise use in ARDS patient. Another trial recently published last year, which is a famous trial called ROSE trial, also published in New England Journal of Medicine. It addressed the outcome of using the neuromuscular blockade early in ARDS. And they concluded that also the rate of ICU acquired weakness assessed in this trial were not different between both groups, patient who receive muscle paralysis or patient did not receive. So this is also was an important study, which is the ROSE trial, and they use it in moderate to severe ARDS also. This is just a comparison between those two famous trials, because when you review literature, you will find those two big trials, famous trials, one published in 2010 in France, one in 2019 in the United States, which is the ROSE trial. This a comparison regarding the trial design, regarding the trial design. Curacious was double-blinded. This is ROSE was unblinded. The use of ARDS definition, the beep use, the Browning intervention, the sedation target. What's something interesting here in the Curacious trial that they use heavy sedation, which is the Ramsey was 6, but here in ROSE was light sedation score. And both they used a fixed dose of 37.5 of cisatracorium, 67.5 milligram per hour of cisatracorium. Another 3 randomized controlled trial assessed the 48-hour infusion of cisatracorium in critically ill adult patients with ARDS. About 400 patients from 20 centers. Their short-term infusion of cisatracorium were associated with lower in-hospital mortality, lower risk of paratrauma, no effect on the duration of mechanical ventilation among survivors, and no increase in the ICU acquired weakness. So we have two trials, the Curacious and ROSE, plus those 3 randomized controlled trials. and also documenting that there is no significant increase in the ICU-acquired weakness among the survivors of ARDS, provided that you use wisely as per indication in moderate to severe ARDS. Because of it's a matter of time, I'm highlighting more evidences about the issue regarding the fear from ICU-acquired weakness and how significant this reported by meta-analysis. Moving now to the corticosteroids, because of the ARDS, commonly we use the steroids, especially if we have COVID pneumonia ARDS. So the steroids toxicity is potentiated by non-depolarizing neuromuscular blockade, such as the pancronium, because they bind to common corticosteroid receptors. But this is very important. So if you are using pancronium, put this in your mind. ICU-acquired weakness is more likely to occur when you have concomitant use of neuromuscular blockade and steroids, high dose of fluorinated corticosteroids. Now we are using DEXA with COVID ARDS. And DEXA is one of the proved steroids that has rule if you compare it, for example, with methylprednisolone. But this high dose of dexamethasone has a high risk of developing ICU-acquired weakness if you are using simultaneously with neuromuscular, non-depolarizing neuromuscular blockade. While the ICU-acquired weakness is less likely to occur if you have short courses, short acting. So remember, short courses, short acting with low dose of corticosteroids. So those are three categories that may help you, or 3 points that may help you to decrease the risk of ICU-acquired weakness in your patient. Short courses, short acting with low dose of corticosteroids. I will highlight about the ventilator associated pneumonia has the neuromuscular blockade does not demonstrate increased risk of ventilator-associated pneumonia. And also this was clear in the corticosteroid that it was not associated with high risk of bacterial pneumonia as thought before. But for the pressure ulcer and coronary ulcers, since 2009, there is a related risk for the pressure ulcers and coronary ulcers when you use neuromuscular blockade. The prevalence of using this, it was translated into one of the biggest studies published this year in the Intensive Care Journal of Medicine, just in last October. It's called the Cube ICU study. It was worldwide prospective observational study. It was conducted in 90 countries. They involved more than 1,000 ICUs, included 13,000 adult ICU patients. They reported the overall pressure ulcer injury and the ICU, its prevalence inside the ICU. So the overall pressure ulcer prevalence was about 26. In the ICU was about 16%. There were broad range of contributing factors. They found that the age, length of ICU stay, diabetes, mechanical ventilation, vasopressors, hypotension, and of course the cardiovascular diseases. But they did not identify the use of neuromuscular blockade as being associated with pressure ulcer as we thought before. So from this D-cube ulcer, they found that the neuromuscular blockade was not important contributing factors if you address it as wise use in patient with ARDS. This is regarding the incidence of exposure keratitis. And please, I'm doing this every day in my round. I'm reminding my nurse, I'm reminding my resident, please, if your patient is having a neuromuscular blockade and deep sedation, please protect the patient eyes with eye coverage, with lubricants, because there is a high risk of exposure keratitis in the ICU. So please do not neglect the unseen. The exposure keratitis is frequently overlooked complications in sedated and intubated patient in general, its incidence is quite high. It's up to 6% of ICU patients, they may develop exposure keratitis up to severe corneal ulcers and opacities. So just moving to monitoring quickly, just I have a few minutes to finish my talk. Monitoring of neuromuscular blockade. Monitoring, I mean monitoring of the depth. And your aim is to limit the development of ischiocord weakness to avoid the deleterious residual neuromuscular blockade after extubation. And this is very important. It will lead to reduction of the amount of neuromuscular blockade, and it will lead to decrease the incidence of persistent neuromuscular blockade. I remember this is a rule, I like it too much in the ICU, which is less is more. Less is doing, more is adding. So the depths of neuromuscular blockade should be assessed every day, repeatedly, by using clinical and qualitative evaluation. Clinical evaluation, I mean that observation of the skeletal muscle movement, monitoring the respiratory effort, and detection of patient ventilatory asynchrony. This is very important. 3 points related to your clinical evaluation every day between you, nurse, and RT. Qualitative, I mean the use of monitoring, objective monitoring, which is the train of 4 or TOF. I will not just go into details. I hope that I have some time just for my colleagues in the ICU to describe some few slides about the TOF. I know all anesthesiologists are aware about the TOF and the TOF ratio and the TOF count, but unfortunately, many intensivists, and I noticed this during the round, and some rotatory fellows and residents, they are not aware about the use of TOF. There is a misconception between TOF and the BIS. And I will just go quickly because the time. So this is the use of the train of 4. I'm sorry for this because I'm short of time. I'm running quickly. So your goal of TOF in managing ARDS, TOF goal between 0 up to 2 twitches, or TOF ratio less than 0.4. This goal indicate between 75 to 90% of receptor blockade. So if you are using the TOF, is a TOF count or TOF ratio. So this is a very important goal to be addressed every day during your round or your round checklist, as far as you are addressing the sedation level. For monitoring the sedation level, comparing the subjective to objective tools. So subjective, all the ICUs are adopting is a Ramsey or RAS, whatever the subjective one. But for the era of COVID, also to minimize your nurse exposure every hour or every time to go in. So there is a rule of using the PES or bispectral index, and this was adopted from and OR actually as based on a cumulative observation of a large number of clinical cases correlating the clinical signs of modified EEG signals. This was comparing the BES or the bispectral index compared to the Ramsey, while we are comparing here subjective to objective tool. So Ramsey was maintained at 6, but if you are looking for the best score is going down from 68 down to 30. So heavily sedated. So if you compare it to Ramsey, BES can be a beneficial tool that you can lighten your sedation to the target level without relying on the Ramsey to avoid the excessive sedation. Moving to the outcome of neuromuscular blockade, this is a summary of randomized control trials, 7 RCTs addressing the role of continuous infusion in neuromuscular blockade with ARDS. Just among those 7, we have 5 trials are positive trials, and we have two big trials in 2010 and 2019 are negative trial about the outcome, the ventilator-free days. And I will tell you why the conflict, because of the timing of enrollment, the ventilatory and non-ventilatory strategies used, the initial severity among patients enrolled, the differences in study design and methodology, and the differences in the reported mortality. So to conclude from those RCTs, the early use of neuromuscular blockade before optimizing the mechanical ventilation and sedation, using a strategy involving a high PEEP level does not modify the outcome. So you have to exhaust your tools with the mechanical ventilation and the high PEEP. Conversely, the neuromuscular blockade, if the sedation alone failed to improve the respiratory status, integrated with the overall strategy, including the recent use of PEEP, proning, and rapid implementation of spontaneous breathing, might improve the prognosis. And if you include the results of the ROSE and other meta-analysis into mortality, so the early improvement of oxygen was also retrieved, and those three meta-analyses, there is a low risk of barotrauma and no effect on the occurrence of ICU-acquired weakness, as I mentioned. And these are the main clinical recommendation used in ICU in clinical practice in terms of preferred neuromuscular blockade is, as I mentioned, is the cisatracurium. The dosing recommendation, there is no consistent recommendation about the appropriate tool of using TOF or not to use, but commonly the TOF is one of the easiest and reliable tool to monitor the use of neuromuscular blockade and the depth of myorelaxant in ICU patients. But till now, till this year, we don't have a strong recommendation to use the TOF. Timing of administration for myorelaxant should be early phase of ARDS. Sedation monitoring goals, as I told you, RAS -4 to -5 before using, of course, the neuromuscular blockade. If we are using BESS, so your target tone of sedation 40 to 60. So just to clarify, BESS is for monitoring the awareness, and sedation has nothing to do with monitoring the muscle relaxant. Muscle relaxant depth is TOF or TOF ratio. Associated measure is the protective lung strategy, PEEP, and plateau pressure as ventilator strategies already mentioned by Dr. Tharwat. The prone positioning as adjunctive will be mentioned by Dr. Faisal. And the duration of administration, of course, only for 48 hours at the acute phase of ARDS. And if the BF ratio is less than 150, plus you should discontinue if the BF ratio is more than 150 and you completed 48 hours. Type, if you complete 48 hours and you discontinue, you will reconsider the use of neuromuscular blockade if needed, if for permissive hypercapnia, for example, of the patient ventricular asynchrony every 12 hours, would like intermittent doses, not a continuous infusion. Safety concern, we talk about it, and this was a very nice publication called the TOF ARDS study addressing the management of paralysis in patients with ventilated patients in ARDS by nurse-directed protocol of terrain-of-4 monitoring, and they found that it was published in 2017. It's called TOF ARDS study. They found that the TOF monitoring seems to be feasible and secure procedure as nurse-directed or nurse-directed protocol. And in our hospital, our department, we are addressing the same protocol. We're adopting this same protocol in our ARDS protocol for our nurses. So we are making the life of our nurses easy through this protocol. It allows a drastic reduction in cisatracurium dosage with a satisfying quality of muscle paralysis. And they concluded that the TOF remains the easiest and the most reliable method available for ICU patients to monitor the depths of neuromuscular blockade. Though there is no strong recommendation from all guidelines to use it as a strong recommendation, and they left it for your settings. By this, I will conclude, and I will sum up with this quotation. Usually, we study the past to understand the present. We understand the present to guide the future. Thank you, and I apologize that I exceeded my time almost by 20 minutes. I apologize for the second time from Dr. Mohamed and Dr. Wafa and from Dr. Saad. Thanks a lot.
Thank you, Dr. Adel. As usual, it was an excellent one. very informative, and I can tell you as an anesthetist, it was very enjoying for us.
جزاك الله خير.
Type to go quick. One question we have about the use of azacurium infusion as a dose and duration ICU. I think you told us in the lecture the cis-azacurium is the golden one.
Exactly.
One of our participants asked about azacurium. Is it used and the dose
Yes,
and duration?
yes, of course. If we are talking about the literature and recommendations, because of the unique feature, as I told you in the presentation, it's one of the isomers of azacurium. It's 4 times potent, and the elimination is unique in its elimination, and it does not cause histamine release, and it's safe in patients with hemodynamic instability. So its safety profile is more than the azacurium, but on the other hand, it's costly. As if you compare the price of using the cis-azacurium compared to azacurium, it's costly than the azacurium. But again, head-to-head, azacurium to use with if you have it or you have a shortage of cis-azacurium, use azacurium. But if you have a luxury in your unit and you have both, use cis-azacurium, of course, as a first line.
Good, thank you. Another one question, you told us about one of mega trial is Rose trial.
Yes.
They use the early use of muscle relaxant. It is more benefit.
Yes.
I'm talking about what is meaning of early use. You told us, Dr. Adel, in the algorithm in the lecture, and one of indication to use muscle relaxant, the PF ratio become less than 150. Yes.
Yes. Yes.
So in this trial, they use this as a indicator to use it, or before even this ratio become 150.
Exactly. So there is some criticism here for the Rose trial. As I told you, there is some conflict for the study designs and the enrollment. But the recommendation now and the guidelines addressing from the Critical Care Society and the European Society as well, they are addressing early. It means away from Rose or Aquarius or any other randomized controlled trial. Now they are addressing the beneficial role, as I mentioned and highlighted in the first slide, that if the PF ratio is less than 150 or less, and with for 48 hours. Yes. So early in the disease, if your patient, you define based on your definition, once you define your patient is ARDS, this is a timing of enrollment and timing of administration. So you will look for your patient, you address the sedation effect, the sedation goal, you exhaust your ventilatory strategies, but you could not reach. So I'm not saying that you should throw muscle relaxant for every patient with BF ratio of 150. No, I'm telling that you have, if you remember this slide I showed earlier, you should start with addressing your protective lung strategy, your ventilator synchrony, and your ARDS not protocol. Once you reach it with the sedation alone, fine. But if still you are struggling with the protective lung strategy with the ventilator setting and ventilator synchrony, of course, your PF ratio is less than 150, so you have to use it early as possible. And short for 48 hours.
Thank you, it's clear. Thank you, Dr. Adel. Again, it was a very nice one.